if you can't see, like, Welcome to My Lab by Stephi Cross.
We can see that, Steffi, thank you.
Okay, awesome. Okay, so hi everyone, I'm Steffi and I am currently a trainee biomedical scientist at Kent and Canterbury Hospital. And like Kath said, I've just been asked to share some of the kind of not more interesting, but the unique learning experience that I've had during my time in East Kent Hospitals Trust as a placement student. And kind of at the end, I'm just going to share a little bit about what my job involves as a trainee BMS in haematology, which is what I am at the moment. So a little bit about me. I've been working within the East Kent Trust since about July last year, and I spent a total of 6 months working as a university placement student, which contributed towards my sandwich year. During that time, I spent the first 3 months at Kent and Canterbury Hospital, and then I spent the second 3 months at QEQM. During my time at Kent and Canterbury, I was mainly in reception, and I was just getting to grips with the whole kind of sample journey and what happens from a sample from the moment it comes into us from the phlebotomists to when it's being filed away within the lab. And then during my time at QE, I was put into haematology, where I was able to get kind of a bit more hands-on experience and some bit more specialist knowledge. And whilst I was there, I was able to get a lot of experience at QE on an analyzer called the Sebia. So basically, this is the Sebia analyzer here, and its official long name is Sebia Capillaries Flex Piercing 2. But just to kind of put that into a bit of context, this analyzer is what we use at QEQM to kind of separate hemoglobin in the blood using electrophoresis. And to kind of basically explain the analyzer, here where you see these green lines is where the reagents are. The samples kind of go in here and they would come out on this side here. And within the main body of the analyzer, what would happen is the patient's blood sample would undergo electrophoresis in a very small, very thin capillary tube. And then the analyzer would then kind of look at this at 145 nanometers and convert it into a graph. You can kind of see one of the graphs here, but I'll show you a better one in a minute. Within the East Kent Trust, we primarily use this separation of hemoglobins in our prenatal screening. So the samples that we will get are from pregnant mums, and we will kind of analyze them, like their history and their actual full blood count, to determine whether their blood needs to be screened for potential hemoglobinopathy. To kind of put hemoglobinopathy into context, it's kind of one of the known examples is sickle cell disease, where kind of the red blood cells are shaped like a moon because of the type of hemoglobin that's in the blood there. Okay, so to kind of get a bit more into how do we decide whether to run a sample for our electrophoresis, we have in blue here kind of the requirements for the sample, and then in green are kind of the requirements that need to be fulfilled for the sample to kind of go through the screening process. So there's kind of basic things in the blue section, like it needs to be peripheral blood in an EDTA tube and less than 8 days old. And a part of our basic sample acceptance rules here at East Kent are things like we need to have 3 points of ID, like first name, second name, date of birth or NHS number, hospital number, things like that. We need to make sure the sample has no evidence of tampering, like with the labels, like it doesn't look like someone's taken a bunch of labels off and stuck them on again. And just things like we need to make sure that it is definitely in a purple top tube, and that kind of we haven't got like a purple label with a yellow top on the top. We need to make sure it's all kind of consistent there. So once a sample is asked to be looked at to see if it needs a HBEL screen, there are a couple of things that we need to look at. The first kind of point that we look at is the mean cell volume within the full blood count. If the mean cell volume is less than 27, then the sample will automatically get sent to QEQM and it will be run for a hemoglobinopathy screen. To kind of get another kind of factor that we take into consideration is the family origin. So in antenatal clinic, we'll have what we call a family origin questionnaire form. And that will kind of give us a bit of background on the family history or what type of pregnancy this is. And certain people and ethnic groups are more at risk of a hemoglobinopathy than others. So that kind of also helps us determine who needs to be included within the screening program. And then finally, another really important thing we need to make sure is that the patient hasn't had any red cell transfusion within the past 3 months, because if someone has had a red cell transfusion, if we put our sample through the screening program, we don't know kind of whose blood we're looking at, and we could be looking at someone else's blood that could give completely wrong results, and that wouldn't be very professional or very good at all, and it would definitely not help at all. And another kind of slightly different route that this could take is sometimes if someone is querying whether they have sickle cell disease, or if someone already has sickle cell disease, we can use the hemoglobinopathy screen to monitor it. And if that's the case, then they won't need an FOQ, because we may already know that they have sickle cell disease, and we just need to know whether the percentage of that type of hemoglobin has increased in the sample or not. So that's one kind of slightly different example that we could have seen in the lab. So once a sample has come, slightly different slide to what I was expecting. This is sort of a summary of the basic daily routine that I would have to do on the Sebia during my time as a trainee. I'm just going to move that up there. So I'd come in the lab first thing in the morning, and I would need to kind of check all the reagent levels, make sure that they were all within date and that was all fine. And the points that I've underlined here are like weekly tasks that I'd do often on a Monday. So I just kind of clean the capillary tubes, make sure that the sample probe was well cleaned, because we have one probe that would go into all the different samples, and also just empty the waste container. Something that you probably will have heard a lot about as a part of your portfolio is quality control. So before any patient samples are run every day, we would run the normal quality control. And on Mondays, we would also run the normal and abnormal control. And that would show us a graph of kind of different types of hemoglobin variants, which are very abnormal, not what you would expect. But we need to make sure that our analyzers can pick those up in case it does appear in a patient sample. I'd also need to, within part of the daily routine, is to look at the samples that have been potentially put forward for the hemoglobinopathy screening. And I would just need to kind of go do what I said just now about looking at the mean cell volume, looking at the family origin questionnaire, just making sure how old that sample is and checking the transfusion history. And then I would kind of bring together all the samples that we had and run them, as we could only run them within batches of 8 because the racks were quite small for the Sebia. And then finally, once all that was done, because we'd at QEQ, we would run samples from Kenton Canterbury Hospital and the William Harvey in Ashford, which were also within our trust. The results would need to be printed out and checked by a BMS. And any kind of really unusual hemoglobin variants like hemoglobin S or E, or in very rare cases Z, they would need to be looked at by a BMS, and then they would need to be referred to another lab for kind of further testing, which is external referral for us. Oh, has my computer crashed? No, there we go. Okay, so what I have here is what a normal patient result would typically look like. This is actually the normal QC graph, but it kind of has all the main details and the points that I would want to talk about for a patient result. So what you have here in this main peak is this is the major kind of band in the electrophoresis that the analyzers picked up, And as you can say, it's form A. So I mentioned just now about how you can have hemoglobin S, which would be should be shown by a little peak here. If you had hemoglobin F, it would be a little peak here, that sort of thing. So that's kind of, whenever you get patient results, that's the first thing you kind of need to look at after checking that the names and date of births and things match, is what sort of peaks have you got and how big are those peaks when you look at them. And then this would be produced for each patient that you have. So say if I ran two racks of samples, I'd get 16 graphs, which is quite a lot to look at. And that would need to be paired up with the patient FOQ if they had one, and then given over to the BMS. When we would run the pathological quality control, this peak down here would be much higher, much bigger, because it would be an abnormal result. And during our abnormal QC, we would get lots of other peaks kind of in the F column, the D column, the E column, and maybe sometimes the C column, just because we need to make sure that our analyzer was really up and running correctly. There we go. So just on this side here, I've kind of put a couple of examples of troubleshooting that I might have to do during my time at QEQM and setting up the analyzer, that just kind of got me and helped teach me get into the hang of just dealing with analyzer problems, because that's quite a common thing in the lab. So for example, if an IQC failure popped up, the kind of process that I'd go through in my head was make sure that the material was in date and that it had completely defrosted, because if it was still frozen, the analyzer couldn't aspirate it and that could cause an error. If the QC had also been frozen and defrosted too many times, that could cause it to expire or not produce accurate results. Also, another example would be from when sometimes the results weren't released from the software, which was a bit frustrating. And in that case, it was just a simple turn it off and back on again kind of problem, which sometimes is just the thing we need to do within the lab. And another kind of error that would sometimes come up would be that the analyzer wouldn't take up the sample properly. This could have been because sometimes the reagent levels weren't high enough, and because we didn't have enough reagent, it couldn't run the sample through the capillary tube properly, and so it couldn't create the bands and it couldn't kind of create results. Sometimes as well, there wasn't enough sample volume. That could be an issue. Or sometimes the sample probe kind of just missed a part, it didn't pierce through the lid properly. And if that was the case, sometimes we just had to rerun the patient sample and see if it would work the second time around. So that was kind of the highlights of my time at QEQM. I'm now going to switch back to what I have been doing at Kent and Canterbury Hospital in the past couple of months. And what I've been doing is primarily working on our new analyzer, which is the Abbott Alinity, the CNI series, which is basically this analyzer here. If you're wondering why I've got a picture of Professor Bunsen in the corner, that's its kind of nickname. We give a nickname to our analyzers within East Kent, and this one is called Bunsen. So if I start referring to Bunsen, this is what I'm talking about. So yeah, this is our new analyzer that we've had within the lab for the past, I think, couple of months. At the moment, it's not currently in use because we are doing what's called patient evaluation, and we're testing this analyzer to make sure that it produces results that would be suitable for use within the hospital or for our GP work that we do within our trust, basically. So to give a breakdown, what is patient evaluation and why do it? So patient evaluation is basically just making sure that the analyzer is producing the correct results. And we kind of need to make sure that we have known values to compare this analyzer to. Bunsen that we have here at Kent and Canterbury, we are comparing to the new analyzer at QEQM, which I think is Scooby. So that's kind of Scooby is like our baseline, and we're comparing Bunsen to Scooby. And basically with patient evaluation, what we're aiming to do is make sure our analyzer gives accurate results, and that if someone went to have a blood test in Margate, if the same day they went and had one at Kent and Canterbury and our site, the results would be fairly similar. They wouldn't be super, super different. Analyzers can cope with the high workload that we're going to be putting through them, and it just allows the staff to get some basic training and understanding of the analyzer. And patient evaluation needs to be performed for every test offered with on-site. So within the role that I was doing, I was looking at these basic tests here, and I was running these on Bunsen. This isn't every test that is available at Kent and Canterbury, because some were more specialised and done with more senior members of staff. But these were the tests that I primarily focused on, and these two here were panels of tests. So general chemistry was sodium, potassium, chloride, gamma GT, alkaline phosphatase, that kind of stuff. And the immunology, it was kind of these ones that were mentioned here. And so just to kind of give like a basic summary of what patient evaluation involves, I'm hoping that this isn't too confusing, but I'll kind of chat through it a little bit at the moment. So to start off with, for each test that is a part of the patient evaluation, you need to start off with 9 samples, and these need to cover a range of low range, mid range and high range values, basically. So for the first day of patient evaluation, you need 9 samples for 10 tests, which was 90 samples to kind of start off with. And the next thing you kind of do on the first day of patient evaluation is you'd kind of set up your analyzer, do the daily maintenance, check the reagent levels that they were all okay. And then you would calibrate and QC the analyzer, and you need to do that for every single test that you're going to run that day. So every day I'd be doing the general chemistry, immunology, gentamicin, vancomycin, that was on that list on the previous slide. And it, of course, must all pass and be well within the set reference ranges that we have made for that analyzer. And then the next stage is to run all the samples, all 90 of them, and then we have to repeat them again, because that is a part of our result processing that we will then have to do. And then, because we are comparing the same samples between the analyzer at Kent and Canterbury and QEQM, we have to transport the samples between the 2 sites. So the way that we did it here at East Kent was we would run the samples at QEQM, and then they would go on to Ashford to be run again. To here at Kent and Canterbury to be run again. And this process had to be repeated every day for 5 consecutive days, using new samples each day, which was quite a challenge, especially having to kind of take into consideration that the samples can't be too old and they can't be too short. They need to have sufficient volume, and if there are any aspiration errors on the analyzers, they must be repeated and rerun again. So it was quite a mammoth task. And then finally, the last stage of this patient evaluation is to analyse the results. And what needs to happen is we need to compare the results between the 2 analysers and make sure that they're similar enough to each other to allow our new analyzer to kind of be let loose into our hospital and to give out patient results. At the moment, our patient results are still being processed, and we still don't know whether our analyzer is ready to rock and roll. So that's kind of a bit of a mystery that we have in our lab at the moment. That's kind of been my main focus within my past couple of months at Kent and Canterbury, and I'm just going to share a couple of things that I've been doing since starting as a trainee within the haematology department. So since the start of my placement year, I've been doing my registration portfolio. That's been it's been an interesting journey, but hopefully I'm nearly finished. That's what I'm hoping for. Having worked in chemistry and haematology, I've been doing a lot of analyzer maintenance and QC and calibration, and it's given me a really good opportunity to be able to see the differences between the 2 disciplines and how they treat failures in quality control or calibration in different ways. In haematology, I've also been looking into result validation, so kind of looking at a patient's clinical details, seeing if abnormal results can be explained, or seeing what just the normal values are for patients are, and what kind of results can look like for patients in different types of wards. So, for example, patients undergoing chemotherapy, or with hematological malignancies, or with renal failure. That's kind of what I'm starting to understand now at the moment. And then also I've been doing kind of checking the critical samples, so making sure that samples from the day before have been phoned out, or a film has been made on them, and that they've been kind of securely dealt with before moving on to the next day's workload. So yeah, that's everything that I've been doing as a trainee now. And thanks very much for listening. Has anyone got any questions that they'd like to ask?
Thank you very much, Steffi. That was excellent. I was delighted to learn something today, actually.